We are moving right along. Welcome to our virtual training number 3. As always, we're going to start off with a little bit of review of the previously learned information, so you can go through this at your own pace and then jump forward to the new topics for this week. We're going to begin with reviewing our chairside procedures.
Setting up for a sealant procedure is one of the more basic procedures and involves very minimal instruments and very minimal items that you need to set up. You will need your mouth mirror, your explorer, your cotton pliers, acid etch with a new tip, which these tips are disposable for every patient, so you will untwist, throw away the tip, wipe down the tube and put a new tip on after each patient. Same for your sealant. Miller forceps with articulating paper. Floss so you can check interproximals to ensure that you didn't get floss in those. Pumice. Your straight nose cone with your prophy cup, which all attach to the slow speed motor. Cotton rolls, triangles, 2x2s to help isolate the tooth and keep it nice and dry. Your high speed and slow speed should be kind of handy in case you need to remove filled sealant material. Your curing light and any appropriate PPEs. Prior to a sealant procedure, you're going to have your doctor examine the tooth to ensure that there isn't any decay. Should there be signs of decalcification or a frank lesion, decay, then the tooth would not be eligible for a sealant to be performed. They would then have to move into a more restorative procedure. Typically, we like to combine a sealant procedure with the same day that they're getting their dental cleaning, just to make use of everyone's time. We're going to start off by checking for decay. Whenever we hand our instruments over to the doctor, we're going to make sure that we hand it to them in the position of use. So if we're working on a mandibular tooth, your explorer, your mouth mirror, and any other items that you give them should be positioned so that they go right in and are able to use them. Should we be working with a right-handed dominant doctor, then the explorer goes into their right hand and the mouth mirror into their left hand. They then will march around the tooth, checking for signs of decalcification or decay, and give the go-ahead if they are good. If this is immediately following the dental cleaning, then what's really beneficial is that they've already had this step completed, which is the pumice with the prophy paste on the straight nose cone attached to a slow speed motor that you then can press down on the rheostat and use. Now, if you're a dental assistant without your coronal polish license, then this is a step that you are not allowed to do. Even if you have been trained on the sealants and can do that after you've been certified and take the course, the coronal polish is an additional course. So they will polish the teeth, removing the plaque off of these occlusal surfaces. After that's been rinsed clean, then we can start by isolating the tooth. Handing your doctor cotton rolls can be done either with just your bare hands or with cotton pliers so that they can grab and use them. We will place one under the lingual area, so under the tongue. We're also going to place one on the buccal surface. Next, we're going to hand them the etchant underneath the chin in the position of use so that the doctor may grab and start working. We always want to anticipate their needs, so understanding your procedure from start to finish is going to allow you to be able to have the next step ready and waiting. The etchant is going to be syringed onto the occlusal surfaces and any of the other pits and fissures that are going to be filled, so maybe there's a little bit on the buccal or on the lingual. And it's going to sit there for 30 seconds. And what this is doing is it's removing the smear layer. After that's sat for 30 seconds, then you are going to rinse and dry for 30 seconds. You're going to take your HV and place it right against the tooth to help prevent them from getting this acid etch on their tongue. It's a really bitter taste. We're going to take our air water syringe and we're going to place our thumb on both the water and the air button simultaneously to get our power washer. When your doctor requests that you dry the tooth, they're not saying take your suction to the tooth. They're saying take the air of your little mini hair dryer and dry that tooth thoroughly. At this point, you may want to switch out your cotton rolls for ones that are not wet because we really need this tooth to stay completely isolated and dry. At which point you may choose to use the Dri-Angles. The Dri-Angles, which are triangular pieces of cotton, we kind of get them loosened up, placed into the cheek to help soak up the saliva on the buccal surface, with this tapered in going towards the back of the mouth. Next, what we can do is grab our sealant. We're still going to give it to the doctor under the patient's chin in the position of use so they can grab and start using. When it comes to sealants, less is more, so you really don't need a lot. They're going to use just a pinpoint amount of it. And I can anticipate their needs and have the Explorer ready and waiting, where they then will take their Explorer and start moving that sealant down into all the grooves that we want to protect against decay. Once they are satisfied with the placement of the sealant, then we will cure it with the curing light. P for R's turns the power on. M for mode will change the setting that you have on it. You can hover it over the tooth, but don't touch the tooth, and we're going to cure for 20 seconds. You can safely look at the light through the orange shield without being concerned of it damaging your eyes, but try to avoid looking at the light while it's working. The doctor then will check to ensure things are fully cured, there's no voids. If there are voids, now is the best time to add a little bit more sealant. This way, they don't have to worry about keeping that tooth dry. It's already being maintained, that isolated area. Once you've done one sealant with your doctor, you've done basically all of them because it's repetitive. Throughout this procedure, if the patient's mouth begins to fill with saliva, then what you'll want to do is grab your saliva ejector and go to the corners of the mouth and do a quick suction. Always ensuring you don't accidentally rinse the sealant. You don't want to use any water or rinse after the etch step has been dried. Once it is cured, it doesn't matter that it gets wet, other than if you wanted to add more sealant, then we'd have to go and re-etch the surface. But if we're happy and satisfied with this result, and we want to check the bite and the interproximals, the best way to remove your cotton rolls in your Dri-Angle is to pre-moisten the cotton roll, pre-moisten the Dri-Angle, and it makes it easier for you to remove it from the patient's mouth. Next, what your doctor will do is they'll take their Miller forceps and articulating paper that to get it placed in, you squeeze, put it in long ways, and it looks like a little flag. You're gonna hand it to the doctor so that when the patient bites together, This metal part is on the outside of the tooth, so you don't want them putting it in and ending up biting down like this. But as they chomp, chomp, and slide side to side, what essentially they're going to be doing is leaving these little trace marks. And as they're doing that, what you want to be looking for is, are there any blue marks on the sealant? And actually, there's a little bit right there on that sealant. The cusp touch, that's normal. It's if you see these little blue halos that we know that that sealant's too high. If you're using an unfilled sealant material, which means that it doesn't have silica or glass components to it, then this will normally wear on its own. But if we're using a filled sealant material, then what your doctor would have to do is go in with either their high speed or with their slow speed and in a burr, typically a round carbide, and remove that excess sealant material. That way it doesn't cause abnormal wear and damage the tooth itself. They'll also take their floss to ensure that nothing got down into the inner proximals. And then the patient is done.
A dental burr is an attachment that's inserted into either your high speed or your slow speed.
Now, to identify the burr, it also helps us to be able to identify which handpiece that burr is designed to go into. So this should be reviewed. The shank end, or the end that actually is inserted into the handpiece itself, this is what determines what handpiece it fits into. The larger in diameter and in length burrs are going to be your lab shanks, and they go into your straight nose cone. So that would be your acrylic burrs, quite a few of those mandrels, and those different, and prophy cups even, but those aren't considered burrs. The second one that we have pictured here, that's a latch type, and that only goes into your slow speed handpiece. The slow speed handpiece, think of it like a key. When you turn a door, or you turn a key to get into a door, you have to line up all these spots for it to work, and that's how that slow speed burr works. You have to kind of twist it into there. The friction grip, which is smooth, that goes only into your high speed handpiece. On the ends here, you'll notice that there are what I'll say are dummy heads. These don't have any real purpose. These are just stand-in, fillers for right now. All we're focused in on is what's in this maroon box currently. We're going to start with the enamel cutting burrs, which are specifically designed for cavity preparations where we prepare the tooth and remove the decay. The straight fissures, if you think of it, they're straight like the barrel of a gun. They're straight up and down. My lines aren't perfectly straight here, but that you kind of get the point there. It's straight up and down. But the plane cut versus the cross cut describes the cutting surfaces. A plane cut has their one set of vertical cuts, whereas a cross cut has their vertical cuts along with their horizontal cuts, hence the name cross cut. So straight fissure describes the shape, plane cut versus cross cut describes the cutting surface there. Let's take a look at another burr that's very similar. Here we have the tapered fissure plane cut, which looks just like the plane cut with the straight, except it tapers off, same with the cross cut. So remember, plane cut and cross cut describe the cutting surface. Straight versus tapered describes, is it straight up and down, is it parallel along the sides, or does it taper off? These burrs will have names. They'll also have associated numbers with them too. This next grouping of burrs are diamond burrs. They come from extra fine all the way to extra coarse, kind of like your sandpaper does. These are typically used in your crown preparation appointments, and their names really describe what they look like. So a diamond flame kind of looks like a flame coming out of a lighter. A tapered flat end, and a football diamond, well, it resembles a football. Rubber points come in a lot of variations. They might be lab burrs, or they might be latch type for your slow speed. As you can see, there's variations to even their heads, but they are designed to polish restoration. So at the end of a composite filling, we want to polish it up, make it nice and shiny and smooth, or polish a denture or a night guard. That's when we'd utilize this burr. Now what we're looking at is a perfect example showing the difference between the head of a burr, which is the actual functioning cutting portion, and the shank of the burr, which is what inserts or connects it to the handpiece. Both of these pictured are round carbides used to remove decay. Those are what are circled in the blue circles there. But they each have a different shank in those red squares. The one on the left is a friction grip shank, which will only work in a high-speed handpiece, whereas the one on the right is a latch type shank, and it would only work in the slow speed. If you try to put it in a different handpiece, it wouldn't actually work. So you'll know clinically whether or not you're doing something wrong. But as we're learning to identify them, split them in half, almost cover the head and first identify the shank. And then cover the shank and identify the head. It's almost like when you were kids and you had those flip books that, it's like, okay, you got the head of an elephant and the feet of an alligator. You kind of switch around those different parts. Think of it that way. You are covering the head and interchanging the shank there. Here's another example of a burr that has two different shanks pictured. The one on the left has a latch type that goes into a slow speed handpiece. And the one on the right, although it's hard to tell because they're not proportional to each other, this is a lab shank. So it would only go into your straight nose cone, the same one that your Profi cup went into with your sealant tray. Now the mandrel itself holds sandpaper disc, which help to sand and smooth and file down chipped teeth or restorations to make them not so rough or gritty. Now a pop-on mandrel versus a screw-on mandrel, a pop-on mandrel, the sandpaper disc is, popped onto it. And then the screw-on mandrel, you screw the sandpaper disc into place. The inverted cone and the pear-shaped cone both have the same function to create what's called an undercut. When we get into, specifically our silver amalgam fillings later in the course, we'll see why this is important for that particular bonding. But an undercut essentially is a ledge or a lip in the cavity preparation that will allow the filling to more effectively hold on to and grip onto the tooth. Inverted cones create more of that distinct boxy, direct edges, whereas the pear shape is more rounded, and you can kind of tell that where it gets its name from, the bottom of a pear is more rounded in that sense. The burrs that we're going to learn, keeping in mind there are lots of burrs and every doctor has their preference, so you'll learn the ones that your doctor likes and when they use them, is the football carbide and the acrylic burr. Now really they are not the same burr and they're distinctly different in their sizes. These are not proportionate by no means. The football carbide is much, much, much smaller than an acrylic burr. But they are both used to adjust restorations. The football carbide is used intraoral or inside the mouth to adjust a restoration like a filling, whereas an acrylic burr is used extraorally or outside of the mouth to adjust dentures and night guards, orthodontic appliances, and things that you would adjust more in that lab type setting. So make sure that you're studying these burrs, particularly on Quizlet. That's going to be your best way of learning and being able to identify them on site.
The Palmer notation system. The Palmer notation system is the numbering system utilized in the orthodontic specialty. The ortho office does not require any specialized training, so when you leave our program, you will be able to jump right in and start working. The numbering system that they use is very particular to their specialty. If you're working in other avenues and specialties of dentistry, you more than likely won't ever work with this numbering system, but it is still very helpful information to know. The orthodontic numbering system, you can think of it a lot like if you are trying to straighten the teeth, you are going to want this in the most aesthetic way possible. So you would want the maxillary and mandibular to be mirror images, but also the right and the left to be mirror images. So instead of numbering the teeth 1 through 32 or A through T for the pediatrics, we utilize them from the midline out. That way, from the midline out, everything is symmetrical like a mirror image. All of your central incisors of the adult dentition are 1s. All of your lateral incisors are 2s. Your canines are 3s. Your first premolars are 4. Your second premolars are 5s. Your first molars are 6. Second molars 7, and third molars 8. So you're going from the midline out.
But then that can be a little confusing because then we have 4 of each number in the mouth. And that's where the splitting of the quadrants, or the 4 areas of the mouth, come into play. Think of it as the upper right quadrant as quadrant 1, upper left 2, lower left is quadrant 3, and lower right is quadrant 4. Now we could number it as 1, 1, meaning the first quadrant and the first tooth in it, or 1, 2, with a semicolon between them, meaning the first quadrant and second tooth, which in all of our other avenues of dentistry, we would typically call that tooth tooth number 7. So if it helps, go over top of these teeth, starting with what would be the patient's upper right. So in this case, if we're looking at the screen, it's on the left side of the screen. You'll see where it's written right. Backwards thinking, because it's as though the patient is laying in front of you, mouth stretched wide open. It's the patient's right. So it's opposite on paper and on screen. We would start with number 1, work our way over to the other side with 16, drop down to 17, all the way to 32. And that's going to help us to translate between one system and the next. We can do the same thing with the pediatric mouth, but this time we're using letters rather than numbers. So all the centrals are A's, laterals B, cuspid C, first molars are D's, and second molars are E's, working from the midline out. The little brackets that you see by the numbers and the letters are what are helping you to identify which quadrant. And so as you can tell in the little illustration in the center, it's as though we draw a mark down for the midline and through the middle of the picture like it's the upper and lower. So you can kind of tell if the bracket looks like a backwards L and there's a 2 on it, that would be what we normally call tooth number 7. If it looks like a normal L with a 5, that's what we would typically call tooth number 13. So it's kind of a translation from one system to the next. And you can actually find this in your textbook on the back inside cover. So the hard part on the back of the book, there's all the different numbering systems. You'll see illustrations of the teeth. It's a fantastic resource of the Palmer notation system. In this training video, we're going to go through the placement of elastic separators and the elastic ligature ties that are placed on each individual bracket to hold the arch wire into place. We're going to start off with the elastic ligatures and removing and replacing them. This is the fun part of having braces, where you get to pick the different colors of rubber bands that you want on each tooth. Sometimes patients will pick the same color for both the top and the bottom. They might alternate every other tooth with their school colors or their favorite colors. So it kind of just depends on what they pick. So what we'll do to remove them is we're going to go to the tooth that we want to take it off of, and we're going to carefully get like an explorer or a scaler up and underneath the ligature itself. We're going to pop it off. To replace them, you're going to use what are called Matthews pliers, that when you squeeze them together, they lock into place so that you don't have to keep squeezing them when you have the ligature in the nose. To unlock them, you're going to squeeze them until you can hear them completely click open and release. You're going to go over to your ligature tree and you're going to grab it carefully with the side of the needles. Don't cover the hole, because then that makes it so you can't actually get it around the bracket. Go off to the side, squeeze until it's clicked and you don't have to hold them anymore. Pop it off. Go back to the tooth that you were working on. Loop it over one of those 4 corners. So each of these brackets have 4 corners. Loop it over one corner, and I always like to hold it with one finger so it stays in place. And loop around. And then squeeze until they're released. And you would do this while the arch wire is in place, but our models have it removed just to make it a little bit easier for you. Do be careful with the models that sometimes if you're a little too rough, you can pop the brackets off of these plastic teeth. So that's how you put on and remove the elastic ligatures. Let's look at how to place the elastic separators that you'd actually put in between the interproximals of posterior teeth prior to the brackets being placed, because what it does is it helps create a space for the molar bands to then go around the tooth. You're going to take your separating pliers that when you squeeze they open. You're going to place them inside the loop. When you squeeze they open. You're going to go over to the interproximals of a posterior tooth, squeeze, and you can press down just a little bit so that it flosses down in between the teeth. And that stays in there for a few days to help create that interproximal spacing for the molar band then to go around the tooth. So these a lot of times fall out on their own, and if they don't fall out on their own, then what you'll do is just go back through like an Explorer or Scaler and just carefully work those out. Whenever you're working with a posterior class 2 restoration, which is something that involves the interproximal surfaces, so those are those mesial and distal surfaces that are down in between the teeth, we need to utilize something called a matrix system. The matrix system is designed to create a temporary interproximal wall, so something that separates that interproximal surface of the tooth that is diseased from the tooth adjacent to it. So as you're placing that filling, it doesn't end up sticking to the tooth next to it or bonding to the tooth next to it and creating one really large tooth. So the posterior matrix system that's most commonly used is the Toffelmeier matrix retainer or matrix system. This mechanical device actually holds the matrix band, which are these little silver boomerangs, into place, creating that temporary interproximal wall. There are different types of bands that are available. So the bottom one that is smooth is going to be our universal band, whereas the top one that has those extra little winged protections are what we call the extension band. So these are typically used when you are working with a really deep restoration that can extend below the gum lines. They come in different gauges, so essentially are they considered soft or rigid or hard, is how flexible is that metal. So this one's pretty soft and flexible, whereas this one is a slightly bit more dense material, so it's got a little less play to it, so it doesn't crease as easily and it stays in place a little bit more firmly. Prior to the band being placed on the tooth, what a lot of dentists and EFTAs prefer to do is to take an instrument like a burnisher and to rub it along the sides of the band to create a more contoured shape, more natural to the anatomy of the tooth. As an assistant, without being trained as an EFTA, we are simply setting up this Toffelmeier prior to the appointment beginning. So you're not actually putting this on the mouth, which later we'll see what that looks like inside the mouth, but we are setting it up when we look at the schedule and we see tooth number 30 has an MO, tooth number 20 has a DO, so then we know that they're going to need some sort of a posterior matrix system. The retainers also come in some variations. So we've got ones that are specific for the mandible. You'll see that it kind of has that angled part. And then we have our one that we're going to use in class that's more of that universal. Now there are different parts of this Toffelmeier that we want to kind of talk through here so we understand when I'm using this terminology, what exactly am I talking about? When we talk about the knobs, we're talking about these two on this end. The smaller knob is what screws the spindle, so the screw-like structure, and pinches the band into place so it won't fall out. The large knob, as you twist it, you'll notice that it moves the box, we call that the vise, up and down the spindle, which then in turn changes the diameter of the band. Obviously, then this is called the vise, and in the vise, there's a little horizontal slit that goes through it, and that's where the tail ends of your bands will go. And on this end, we have these sets of prongs. We have one set, and we have our second set. You'll notice that it kind of has a U shape to it. Anytime that we're setting this up, whether it's for the upper, lower, right, or left, you're going to want to make sure that that U is facing up towards the sky. So this is what you should see whenever you're setting up the Tafelmeier. You should also have your band always shaped like a V. So we don't want to see a tint, because what happens is if you take these tail ends, which is this end and this end, and you close them together to create an uncreased loop, like so, you'll notice that on one end of that loop, it's a little bit smaller in diameter than this end. You can kind of see it funneling up. That funnel needs to be directed towards the gum line, and so does these prongs. So when you're holding this up like a U, that's for the upper arch, and when you're holding it down like an N, that's for the lower arch. What that's going to ensure then is that the smaller end of that loop, this end here, that's the end that's going to go towards the gum line. If you think about the shape and anatomy of a tooth, as we get towards that gingival third, which is the gum line area of the tooth, it does get a little bit smaller in diameter. And so this creates that natural shape of the tooth. We take our uncreased loop without flipping it and turning it as we go. So always making sure that if we open it, it still looks like a V. We touch tail end to tail end. We're going to take those tails and we're going to slide it right down into the horizontal slit and allow it to go straight through. Now, if for some reason it doesn't want to go all the way down, what probably is occurring is that the spindle, so the screw, is in the way. So it's all the way up inside the vise and it's just not allowing it. So mess with the small knob, and then it should slide down without any interruptions. But we don't want to leave it like this because right now it's really loose. It could pop off and it's not going to be useful. So if you want to tighten that band into place so it won't pop out, you'd use the small knob. But before we do that, let's determine where this band actually needs to be directed, because right now it's not going to be useful for any particular region in the mouth. So if I'm working in the upper right hand quadrant, so that's tooth numbers 1 really through 5, we don't use this on an anterior tooth, we're going to take this band, we're going to keep our thumb on this little horizontal slit so it doesn't pop out. I'm going to take my band out of not the first set but the second set of prongs and use those as directional prongs that will turn it to the right side. So upper right to the right. Upper left, we're going to take that and we're going to turn it to the left side. So upper right to the right, upper left to the left. Now when this fits inside the mouth, this is a lower arch, so it's going to look a little bit different than me holding it in, but this is what it's going to look like inside the mouth, where the retainer itself is on the buccal surface. The band is always facing towards the tooth you're working on. If it's a lower, in this case, the U is facing down to make the letter N essentially, and the smaller end of the band is going towards the gum line. But if I were to take something that is set up currently for the upper left, and you know that because the band's to the left, and if it's for an upper, the U shapes up, but if it's a lower, it faces down. If I try to put this in the lower left quadrant, look what happens. That is now not on the buccal surface, and if they try to bite together, they're going to bite on the retainer. So even though this works for the upper left because the band's to the left, it will work for the lower right. So upper left to the left, upper right to the right, in opposite quadrants work together when we're talking about the uppers versus the lowers. Now, what a lot of dentists and EFTAs will use in addition to the retainer system is a wedge. So this wooden wedge comes in different sizes and variations and colors, but it typically is wedged in through the lingual embrasure. So that's that little triangular space between your teeth and gums in between teeth. It gets wedged in there and it helps to create a really tight contact. It ensures that the band alone doesn't pop out, and it creates the correct contour with that. So it gets pressed in there through the lingual embrasure. So you know exactly what to set up for based off of looking at the patient's chart. Then what happens is after the tooth is numbed and prepped, you hand the doctor the retainer, they go to place it in, and you'll notice there's some frustration with these retainers because they actually have to get this band around the tooth. So if I know I'm working on a molar, I'm gonna go ahead and keep my band really large. But if I know I'm working on a premolar, what I can do is actually take that large knob and turn it to make the diameter just a little bit smaller. You don't want it the exact size because we still need to be able to fit it around the tooth. And once it's on the tooth, they'll cinch it even tighter, almost like cinching a belt closed. So they'll keep turning the knob until that gets tighter and tighter around the tooth. But it saves them some time and they don't have to adjust as much. So in review, this is your Toffelmeier matrix retainer. It is a posterior matrix system designed to create a temporary wall between the tooth that it surrounds and the tooth adjacent to it. So as you place that mesial or that distal restoration, it doesn't stick to the tooth next to it. When you're putting it in, you're always going to want to make sure that the prongs are facing skyward so that you can see everything. So you should be able to see the vise and the horizontal slit. Your band should look like a V, not like a tent. So what happens a lot of times is we close it together, and then when we go to put it in the retainer, we do one of these numbers, a little acrobatic act, and we don't want to do that. So we're going to take that and we're going to slide it straight down into those little horizontal slits without creasing this. That's important. If you crease it, this is not going to create the natural contour of a tooth, so make sure that you're not creasing it. If you want this to work for the upper right, then what you'll do is you'll take that band and you'll direct it to the right. If we want it to work for the upper left, the band is directed to the left. Noticing that the smaller end of that band, that smaller end of the loop, is facing the same direction as the prongs, which would be near the gums. When we're done and have it positioned where we want, we're going to tighten it into place with this screw. If we want to change the diameter, we use the larger knob. And opposite quadrants are the same. So if this works for the upper left, this also works for the lower right.
Going through the parts of the aspirating anesthetic syringe. What we're going to look at first is going to be the threaded tip. This is where you're going to screw on your needle. Your piston, which goes up and down inside of the syringe with the harpoon on one end and the thumb ring on the other, where the dentist would hold, or even the hygienist would hold, to actually plunge and put the medication into the patient's mouth. You've got blue and yellow needles. Typically, your blue is going to be for your maxillary and your yellow going to be for your mandibular, with the clear end being your hub end that's screwed onto the syringe, and the blue the injection side. Looking at your anesthetic carpules, you'll look for whether or not it has epinephrine in it, the expiration date, looking for any kind of discoloration, bubbles, looking as though some of the material has been used, because we do not want to use a carpule that's been used on another patient. You could also tell if it's been used by looking at the top in that diaphragm to see whether or not you see a puncture from the needle. We definitely don't want to use that on one patient to the next. You also want to utilize, if your office has it handy, some kind of safe needle recapping. Let's start by taking off the hub end of the needle. That's the clear side of the needle. Carefully taking the sterile needle, you're going to screw it onto that threaded tip, making sure that it's screwed completely down where the plastic meets the metal without over tightening it to where it's really difficult to take off later. Then you will place your hands on the piston, pulling it back. Otherwise, you're not going to be able to fit your carpule in there, and you'll know because you won't be able to get it in. But you're going to pull it back so it's out of the way, placing the rubber end towards the harpoon, the little part that looks like a fishing hook, and the metal cap towards the needle. And you'll notice that it's kind of loose. So you're going to firmly hold that and spank the thumb hole so that it engages with the harpoon. Always make sure that you're handling needles safely. These I really like, the protectors, because if you were to go to recap it, acts like a shield, so you can't accidentally stick yourself. One way that you can check whether you've assembled it properly is to give it a little bit of a squeeze to make sure that that fluid is coming out. But let's say that your office doesn't have one of these needle protectors. You can simply scoop and press that lid on as a safe way for you to recap that needle without injuring yourself. Now, to disassemble it, you essentially work backwards. You're going to quickly pull back on that piston, slide down, and remove the anesthetic, which sometimes that rubber stopper gets stuck on the harpoon, which is fine. Just make sure you're not using your finger to pull it off the harpoon because that's really sharp and can cut you. That can be disposed of. And the needle is going to be unscrewed. Now, I like to bend the needle when I take it off and put it directly into our sharps container. Do not try to recap it with the hub end because you can accidentally stick yourself in that side. It's still considered contaminated. So you'll put that directly into your sharps container, which should be located in each of your operatories. You can put your carpal in there also. We've actually got quite a bit of topics to go over for this week, including our treatment planning, our restorative composite procedure, impressions and pores, pathology, microbiology, and disease transmission. There's going to be a lot of virtual training on clinical skills this week, and we're going to really hit these heavy when you come into your clinical. So we really need you on the top of your game, watching over these videos, not just once, but do a quick refresher before you come into class on the things that maybe you felt were a little challenging to understand in the video, so that you can bring in those questions and be ready to just jump in chairside and get going with each of those skills. When a patient becomes established in your office, we will not only look at the restorations that are already there, but determine whether or not the patient is in need of any treatment. Each time that the patient comes in, the doctor is going to perform an exam to make sure that there is or is not something that needs to be addressed. And this is where treatment planning comes into play. This is not just something that the front desk does. In a lot of offices, the clinical assistant does go over treatment with a patient on what needs to be done, how the procedure is ran, and sometimes even the cost and how their insurance benefits might work in these particular scenarios. And while you may not be interested in being a front office staff member, there are times that you want to be cross-trained so you have a better understanding of what's happening with your patient's care. We do have some papers in our workbook that go along with this next section. So once you jump onto that video, then you can pause, flip open to those pages, and follow along with it because there is a little bit of math. Don't worry, the beauty of it is it's going to be simple, and majority of the time your computer handles it for you anyways. But when we do it by hand, it's going to make better sense as to what's really happening here. Upon selection of your patient in the Open Dental software, you can go to their clinical chart by clicking on the tooth icon on the left. This is where you're going to see a visual representation of things that have been completed by us in blue, completed by other providers in green, so they came in and this was already done, and treatment that we are recommending them to have done in red. So you've got fillings and extractions, and you'll notice that their extractions here are using an X icon, whereas we've been using circles and lines. Nobody's doing it wrong in this situation. It's just this is how the software was set up. How you would input the treatment is you would click on the tooth that you want the treatment applied to, and it will highlight its number. And then you'll go to the right side and you'll see quick buttons where it's got some commonly used procedures, or you can click on the procedure list button. That's going to pull up the whole list of ADA codes that break down into different categories what procedure you want that tooth to have done on it. After you click it, it's going to automatically put it onto there. It's also going to put it in the default view description progress note area of the chart. This is actually where you will put a patient's progress notes. You'll right click the procedure you did that day that's listed there on the screen, and there'll be a section to add notes. You can set up what are called quick notes, where it'll ask you questions like what was the tooth number, what were the tooth surfaces, and you check boxes, and then it auto-populates your progress notes for you, and then you can change and customize it once it's done if you need to. You also have a quick view of the patient's medical history here, medications, significant health history, things like allergies are going to be listed in that patient information section.
We're going to go through a couple different procedures that can be found on your Hammond Dental Care Platinum Plan sheet that breaks down the different dental procedures by their categories. Each of these categories are covered at a different percentage, and that is based on your insurance. So that's what we call a breakdown of benefits. Typically, you see things that fall under the diagnostic and preventative covered at 100%. Restorative, which are fillings, perio, and endo, a lot of times at 80%. Major work like inlays and onlays, crowns, removal of prosthodontics, surgery, implants, those types of things are major work and a lot of times covered at 50%. But that does vary on the insurance. So some insurances I've seen in the diagnostic section, and you have to pay like $5 for a cleaning, which to a patient doesn't seem like much, but in a large business where you have thousands of employees that go twice a year, that extra $5 that they're paying each visit is going to save you a lot of money. Your insurance has a couple of things. You have the breakdown of benefits, but you also have a maximum. The maximum is, think of it like your piggy bank. You can only use whatever is in your piggy bank, but you can't just use it on whatever you want. Insurance is kind of like a coupon. Like it's got certain percentages off certain procedures. It's either 100% off or it might be 80% off, but it's based off of your coverage that maybe you picked if you had options to pick. Now let's go through a treatment plan. The patient comes in and they are going to get an exam. Now this is a comprehensive exam. It's the first time they've ever been in the office before. So if we look at the ADA code 0150, this is a universal way of communicating, saying that they got an oral evaluation. It's comprehensive, meaning that we're looking at every single tooth in the mouth, looking for periodontal disease, evaluating what's missing, what's already present, all based off of that exam. Now the fee could either be a UCR, which is the usual customary rate, and that's what we charge everybody, or it may be an in-network fee. An in-network fee is if the insurance and the dentist have an agreement that the dentist will charge their customers less money, so their subscribers less money, it will save the insurance money, it will guarantee that the dentist gets patients, and then the patient ultimately wins out in the end too. In case they have to pay anything out of pocket, there's a discount. For our purposes, we're going to stick with the UCR. So if you have a sheet that says the member rate, go ahead and just scribble that out. We are only dealing with the UCR for our purposes. So if we look under the diagnostic and preventative section at the code 0150, the UCR is $78. Everything in this category is covered at 100%. So you could very easily just say in this column, we're going to estimate the insurance to pay $78. Now it does help us to understand where this number is coming from, and I'm not the biggest fan of math. I'm guessing you might not be either, but here's how it works. We take the fee of $78 and we times it by the percentage that it's covered at. So if we times it by 100%, it's multiplied by 1 and gives us 78. Then for the patient out of pocket, we take the fee of $78. We subtract the estimated coverage of $78 and it leaves us $0. Even though the patient's out of pocket is 0, that number, that money is coming from somewhere. It's coming from the maximum. So we have to take what's in the maximum currently, and this usually is reset every single calendar year, and we are subtracting every bit that the insurance pays. So they're going to take away the $78. This does not affect patient out of pocket. Currently, it is just subtracting the $78 from $1,500. So you should have $1,422 left over in your maximum. And this is for any dental procedure. So if you went to a periodontist, to an oral surgeon, and then to your general dentist, they're all pulling from the same funds other than orthodontics. A lot of times they have their own fund, their own ortho coverage if that's part of your plan. This patient also got a filling done that day. Let's say that they wanted some same-day treatment. Typically you'd see an exam, x-rays, and cleaning on that first appointment, but let's say they got an exam and they got a filling. So we're going to do tooth number 2, MO. So it's 2 surfaces because it's the mesial and it's the occlusal, and it's 2 surfaces on a posterior tooth because tooth number 2 is a posterior tooth. So if you look under the restorative section, for the code, we're going to do composite, so that's what resin is. Resin, 2 surface posterior is a 2392. That's what we're sending out to insurance saying, yeah, we did a 2392 on tooth number 2 on surfaces MO. The fee is $215. Now, that's a lot of money. If you had no insurance, there would be no estimated insurance. All of the fees are your out-of-pocket. We're going to take our fee of $215. We're going to times it by the coverage. Now this is the restorative section, so the coverage is going to be different. It's going to be covered at 80%, so we're going to multiply it by 0.8. And so the estimated coverage is $172. Now we're on to the estimated patient out of pocket, which is the fee of $215 minus the $172. Because the difference is what obviously is left over from what we charged and what insurance didn't pay. It's called co-insurance, and that's going to leave us with $43. But keep in mind, there's something called a deductible, typically anywhere from $50 to $100 per patient, usually with a family maximum of that. But this is done on the very first restorative or major work of the year, and it's only on that first procedure. It's not every procedure after that. So if you get a filling done on January 1st, you pay it, and you never pay that extra $50 the whole year. Or if you get a filling done on December 30th, you pay that $50, and then as soon as the new year rolls around, if you need a procedure done again, you have to pay it again. So really their out-of-pocket that they should expect to bring that day is $93. That $50 only affects the patient's out-of-pocket, so make sure not to subtract that from the maximum. You're going to take the $1,422 that was left, and you're going to subtract the $172. Because it's what the insurance is paying, not what the patient is paying that comes out of that amount. It is what the insurance pays. So that leaves us with $1,250. Last procedure we're going to treatment plan is going to be an extraction of number 5. If you were to look under your oral surgery section, and we'll say this insurance covers it at 50%. If it's an extraction of an erupted tooth, $71.40, that's a simple extraction in our book, with a fee of $173, this is covered at 50%. So it's 173 multiplied by 0.5. So make sure you're typing that out and you're practicing along with this. That way you get an idea of how to do this math on your own, because you will have to do it on the exam. So it's $86.50. If I did the math and I subtracted the fee of 73, or subtracted $86.50 rather from the fee, it would leave us with $86.50. It's that 50 right down the middle. So that's kind of easy to do. We're down at the maximum at $12.50, and this time we're taking the $86.50, but make sure you understand where it's coming from. Even though the numbers are the same, it's not always that case. So the numbers have to come from the insurance column. So when we subtract $86.50, it leaves us with $1,163.50. If we were to utilize all of this insurance in 1 year, it's called maxing out. And that's where it's beneficial to go to an in-network provider. So let's say if this maximum got all the way down to 0 and you needed a crown. If you were to look in the crowns and bridges section, instead of paying the UCR, you'd be paying that lesser member rate. So it benefits you because even though, yes, you're still paying a big chunk out of pocket, you get a discounted rate if you go to an in-network provider. Some insurances require this, where you have to go to an in-network provider, where you cannot pick and choose your providers. And there's some insurances where the premium is so little, so you're not paying a ton. Your options are very limited. Your coverage is very limited. And I've even seen some where they tell you what dentist you have to go to. So this gives you a good understanding of treatment plans and where the numbers are coming from, so you can better explain them to your patients.
In the Open Dental software, there is a section specifically for your treatment plan. When it's added in the chart section, which is the icon with the tooth, you'll see a visual representation of treatment that's already been completed, what needs to be done, the progress notes, all those things are there. But the treatment plan section is going to break it down in the financial side of things. You can create priorities and determine that these things should be done first, and then second, and then third. It'll tell us what teeth numbers and surfaces we're working with and the ADA codes associated with that. It'll also have the description and breaks it down for our patients. The first column is our office fee. What do we charge for that? The allowed amount is a negotiated amount. If you're an in-network provider, this is going to drop that amount down. Then we have our primary insurance, and we're estimating. I always emphasize that when I speak, that this is your insurance estimate, because I don't want to guarantee or promise something and then the insurance company not follow through with that, and then I look like I was being the one that was dishonest. So I say, this is what I estimate your insurance to pay. If they have secondary insurance, it'll calculate it in there too. If it's an in-network provider, it will have a discount section, and then the patient portion is calculated on the far right. You can see the columns on the bottom right that have the annual maximum and deductible in there. It keeps track of how much is being used, at least in our office. This would have to be manually updated if they went, say, to an oral surgeon or a endodontist. They all still pull from the exact same maximum we are. At the top, you can save the treatment plan and then print it off, go over it with the patient, have them sign it. That way, you can scan it into their chart and you have proof that you went over it. So if they were to not follow through with treatment and something big arises because they didn't, they can't come back after the practice. If you perform treatment and they decide that you never told them how much it was going to cost, you can pull this document up and show to them that they were made aware of it and they agreed to the terms. It's also really helpful too, as the patient, to have something to go back to and refer to if we didn't schedule the day of and we wanted to go home and think about the financial side of it, because there are things in dentistry that are really expensive and a patient's just not able to commit to treatment right off the bat. They need to go home and figure out how, or if this is something that they can take care of financially. There is a card that they can sign up for. It's called Care Credit. Care Credit is a credit card that is specifically designed to be used in the medical setting, so it's not something they can go on a shopping spree with. That money can only be used at a medical or dental office. If a patient has gotten dental caries, then they are no longer a candidate for just being a preventative patient. We've got to bring them in, get the decay removed and filled. And a lot of offices are using composite, which is the tooth colored filling material, because it is more aesthetic, it's pretty durable. It's a little bit more expensive than the amalgam, and so some insurances will do what we call a downgrade, where they'll pay the silver filling fee even if you did a tooth colored filling on a back tooth, because they said that you've chosen to do an aesthetic option. Even if your office doesn't do any silver fillings at all, it doesn't matter. They're going to still downgrade it for some insurances. We will actually be assisting and placing composite fillings in our clinical. This is not going to take place of you getting your EFTA training and then being legally allowed to place fillings in an office. So don't mistake this as training for that. That is additional credentials that you must obtain after graduation. It takes a few years to qualify for that training, and it's definitely well worth it. But when you get to take the doctor's role during the clinical, what it's going to allow you to do is feel and see how those materials work and interact in the mouth, so you get a better understanding as an assistant how that procedure should go.
The following training video is a composite procedure video designed to help the dental assistant to better understand the general steps of most composite filling procedures. This is not to take place of going to dental school or getting your training as an EFTA. It is simply to help you understand what typically occurs during a composite procedure appointment. Prior to the procedure being performed, the treatment would have been treatment plan documented in the chart. The treatment plan and cost would have gone over with the patient, and they would have accepted this treatment and cost and schedule. When you are looking at your schedule for the day, you'll confirm with their treatment plan that that's truly what needs to be done. From there, you're also going to be evaluating their medical history to see what type of anesthetic can you set up. For each patient, you're going to want to make sure that you have topical anesthetic, and you don't need a lot of it. Just a little goes a long way. And you're going to want to set up your syringe, your aspirating anesthetic syringe. Now, when determining what type of needle you're going to be using, this is going to be based off of the area of the mouth you're working on. So if you're working on an anterior or a maxillary tooth, typically your doctor is going to use a blue short needle. If you're working on a posterior mandibular, then typically they're going to be working with the yellow long needle so that they can perform a block injection. Purple needles are used particularly for pediatrics or really small mouths, but some doctors I've seen use only yellows, so it kind of is just a lot of times preference at that point. As you're assembling it, you're going to want to make sure that you take the hub end of the needle off first. This is what I like to stick my topical anesthetic into so that it doesn't get everything else sticky. So I like to stick that right in there and off to the side. Then you're going to take your anesthetic syringe and you're going to line up the needle with the threaded tip, screwing it on, making sure not to over tighten it, otherwise it becomes problematic and that threaded tip tends to come off with the needle. Next, what you're going to do is you're going to determine if the anesthetic that you have, the Carpul, is the correct medication. If they are a heart patient, if they've had any adverse reactions, or they're pregnant, you're going to want to avoid an anesthetic that lists epinephrine as a ingredient. Check the expiration, make sure it's not expired, it's not broken, showing air bubbles or use, or any kind of discoloration, and no puncture marks on the top like this training one is. We're going to put in the rubber stopper in first by pulling back on the piston and the thumb ring, like so. You'll see the harpoon disappears down into it. We're going to place it in, line it up, and gently slide it into place. Firmly grab that syringe and give it a nice firm spank at the end to engage the harpoon into the rubber stopper. And we're going to leave this capped for the doctor so that they can give the injections. When it's time to perform the procedure, the dental assistant may place topical anesthetic in the gum area close to where the injection will be needed. So on a maxillary tooth, they typically are doing what's called an infiltration injection. So the topical will be placed right near the apex of whatever tooth you're working on. If this were mandibular, I would place it near the tooth we're working on both the buccal and the lingual, but also back in the block injection area. And it'll take a couple minutes for it to soak in, to which the doctor's going to come in, give the local injection or the shot, and we'll start the procedure. In a composite filling procedure, especially on anterior teeth, it's extremely important that we get an accurate shade match. Last thing we'd want for our patients to do is walk out with a shade that looks nothing like their natural teeth. You'd want to make sure that you do this under natural light, so the operatory light will be turned away, prior to, preferably before drilling on the tooth, and even before the anesthetic if possible. Once you find a shade that you like, then on each tab, there will be a shade that's listed, and that will coincide with all the composite materials that you're going to be using. During the prep part of the procedure, this is where the doctor will be utilizing their high-speed and slow-speed handpieces. You'll have your HV suction placed to make sure that all that tooth debris and aerosol are getting caught by that. And then we're going to isolate the tooth. Cotton rolls, 2x2s, dry angles, all these cottons are used in basically every procedure, so these are a given that they're going to be out and ready to be used. After the tooth is isolated, the steps are very similar to that of a sealant, which you'll start off by passing over the syringe of the etch to the doctor underneath the patient's chin in the position of use so they can grab and go. I'm going to syringe this on all the prepared surfaces. We call this a prepped tooth. And that's going to sit there for about 30 seconds, to which you then are going to rinse and suction it away. When this 30 seconds is occurring, you can already have your HV and your air water syringe ready because you know that that's going to be there. You should be anticipating your needs. And the more that you work with the doctor, the easier this becomes. Tooth is thoroughly dry because this is a chemically bonded system, so we don't want any moisture being introduced, whether it's through saliva or through the air water syringe. Next, what we're going to be getting is the bond. So what the bond essentially acts like is a super glue. It's the adhesive layer between the tooth and the composite filling. This we don't want to put out ahead of time, because if we do, then what happens is that bond, being a light cured material, will end up hardening in the DAPN dish just like this, and then it's not usable. We're going to recap our bond. Now this is a communal tub, so just make sure that this gets wiped at the end of the procedure. You're going to grab your DAPN dish, your micro brush, and if it bends, so if it has a little perforation, go ahead and bend that. And you're going to hand this to the doctor underneath the patient's chin, ready to go, pre-dipped, and they're going to grab it. I always like to keep my DAPN dish just below the patient's chin throughout this whole step, so that when or if they need to re-dip the bond, then they can. They're going to apply this to the prepared surfaces. There are primer adhesives where they're a liquid etch and a liquid bond. There's a 2-in-1 system. There's also the, like we have, the acid etch and then the liquid bond. Now, if we apply the liquid bond, typically what they're going to want to do is do a quick little air dry, just to ensure that there is no puddles, essentially, of the bond, so no thick layers of it. What I like to do is take my air water syringe tip off to the side and test that it's air first before I do this and end up spraying it with water. 3-second air dry there, so your little hair dryer. You're going to make sure that this curing light is set for 10 seconds, and we're going to cure the bond for 10 seconds. Now I'm thinking ahead, the next step. The doctor is going to want to start applying the composite, but because this particular filling on an anterior tooth happens to be involving the interproximal, so the distal, they're going to want what's called a matrix system, something that's going to go between these two teeth, separating them so that when I place my filling, it doesn't stick to tooth number 7 and end up creating one large tooth. So for the anterior teeth, the matrix system of choice is typically your clear mylar strip. It's just a thin piece of clear plastic that essentially you floss in between the teeth and create a wall between tooth numbers 7 and 8. They can go through with a wooden wedge. This is going to go through the lingual embrasure, so it goes through the tongue side of the tooth and helps to wedge that into place. Doesn't work the greatest on these fake teeth, but definitely does on real teeth. The composite gun, you're already going to have preloaded with your composite, so to take it in and out, it pops in and out very easily in most cases. You would have already selected the correct shades, so you can find the shades on the caps themselves. So this is an A2. This is a one patient use product, so there would be a cap on here you take off prior to handing it to your doctor. Again, under the chin in the position you use so they can grab and go. Thinking the next step ahead, they're going to want some kind of composite placement instrument. There are lots of different instruments that are out there available. The two that we have in our kit setup, we call it our gold composite instrument and our plastic composite instrument, which these we have a couple different colors and different sets, so they might be black or white or clear, but just know that the gold has the gold color and the plastic has the plastic look. There are multiple instruments with different purposes in their design, but really it is just preference as to what your doctor prefers to use, which you'll then know and anticipate that. They're going to squeeze the composite gun to get the composite to start extruding out. And this is a really thick plastic, almost like a paste. And so it can be kind of tricky to get it to stick to the tooth, especially when we're working with these fake plastic teeth. You'll notice that it's a little harder to work on these than a live patient. You know, their tooth might be loose in the socket or this might pop out. So try not to get too frustrated when it comes to the fake teeth. As the doctor is using the placement instrument, a little trick of the trade, it's going to make you look a lot more polished, is you're always going to want to make sure that you have a piece of 2x2 gauze just below the patient's chin. So as they're working, they can stick their instrument out and you will wipe it clean as they go. When they're happy with the shape or they're ready to cure that layer of composite, we are then going to set it for 20 seconds and cure all the surfaces as needed. There are lots of techniques as to placing the composites. You know, it is an art, just like with any other type of art, there's lots of techniques to it. So there is a flowable composite that comes in different shades, like this is an A3. This is just a much thinner material than that paste that we were using, so it's great in really small cracks and crevices. You extrude it out just like you would your sealant material, so you squeeze and it comes out really runny. It also helps to fill in any kind of gaps. So if there's a small gap between the filling that you put in and the tooth itself, then they can go through and squeeze and syringe it in there to help create more of a seamless look to it. Obviously, this is not a very pretty filling we have right now. Different settings for different products. So this one's on like a pulsating setting on the curing light. Other ones are a constant light. Make sure that you know what your product requires. They're always going to want to check the bite, and especially if it's an interproximal, they're going to want to use floss to check in between. But the articulating paper goes into your Miller forceps by squeezing and opening, placing it in like a flag, and having them chomp chomp, slide side to side, to then evaluate should these be adjusted. If they need adjusted, then we can use different burrs like the finishing burr set. Each of these have different names and functions, but collectively, this is a finishing burr set. When they're done, the patient is ready to walk out the door, smile, use that tooth to eat because it is completely set up and there are no restrictions in regards to that. Now, there are restrictions because they're numb. They're definitely not going to want to eat anything that's hot temperature-wise, or maybe they wouldn't know how hot it was. Usually just if the numbing wears off, that's the best time to then go ahead and eat and drink. But it's not going to make it fall out. It's not going to make it, more sensitive, but there can be some sensitivity. Anytime that we work on your teeth, there is that slight chance there can be some sensitivity. So make sure to educate your patient that we just worked on your tooth. It's normal for a couple of days that it might be a little sensitive. Now, if it persists or it's unbearable, give us a call, and it's a possibility that maybe that bite's off because sometimes the bite registration paper doesn't pick up what needs to be fixed. And this should help you to get a better understanding of the general step-by-steps of a composite procedure.
If you've ever had braces or whitening trays, then you more than likely have had some form of impression taken. What we're going to do is introduce the alginate impression and stone pour-up, and that way when we come to our clinicals, we can delve right into taking impressions and pouring them up on each other in class. Dental impressions can be taken for a number of reasons and with a number of different materials like alginate or polyvinyl materials. One way that impressions can be taken, and it's a much more comfortable experience for the patient, is by using a scanning device. This isn't really even an impression anymore. It is a digital scan using a really high-tech piece of equipment that allows us to create a 3D rendering of the mouth to create different things like crowns, dentures, and even our clear aligners that you're going to see like Invisalign and ClearCorrect. Impressions are a vital part of crown and bridge appointments, and the materials that you'll see used for those procedures are going to be different than the one that we're going to take on each other in class. Prior to taking really any impression, but specifically with a full arch impression, you're going to make sure that you're going to try these trays in. Now we're going to use plastic perforated trays. There's metal trays, non-perforated trays, and every office kind of has their own reasoning as to why they like to use one or for the other. Try in those trays to make sure that they are the proper size and fit. They don't need to be too small because we don't want to hit the sides of the teeth, and we don't want them too large where they would be uncomfortable for our patient to wear. Now we are actually going to be taking these impressions to make whitening trays. And so what we want to make sure that we're doing is following the proper mixing ratio for the product that we're using. We're going to start with our alginate powder. We've already tried in our trays. We're going to pre-scoop our powders, and we're going to follow the instructions. And in this case, it's going to be 2 to 2, 3 to 3, depending on what arch that you're working on. And if you're ever unsure of the mixing ratios, you can just simply look at the container of the material. Now that we have our powder in our mixing bowl, we are then going to get our water. Now the water itself, if you use cold water, it's going to slow down that chemical reaction and give you more mixing time. But if you use warm water, it's going to speed it up, which that is beneficial for our patients that we know it's going to be a lot more uncomfortable for them. When we're getting this ratio, when we're measuring it, if it's a 1-to-1 ratio, it's not 1 vial to 1 scoop, it's 1 line to 1 scoop, and then 2 lines to 2 scoops, and 3 lines to 3 scoops. Pour the water directly into your alginate and begin to mix. I like to always just do a little bit of a stir at first to incorporate that water so it doesn't puff everywhere, because this can get pretty messy. And then we're going to use a spatulating motion where you're going to quickly mesh this material together up against the sides of the bowl. We should be able to mix this in about a minute or less, especially for using fast set material. It's going to set up on you pretty fast. So mix it so it's nice and smooth. There aren't any lumps and clumps into it. When we're working on the mandibular arch, you're going to load one side of the tray at a time, scooping out your alginate, making sure it's nice and smooth across it. A little trick to make that even nicer is once it's all in the tray, you can get a little bit of water on the fingertips of your glove and gently gloss it over the top of that alginate, and it's going to make a nice smooth surface. Now that it's loaded, you're going to go over to your patient and place it into the mandibular arch, making sure that their tongue is lifted up. You center it and press from the back to the front so that the excess material is pushed towards the front of the mouth. You're also going to want to make sure that you are keeping constant pressure so that the patient isn't shifting this with their tongue, that their lip is pulled out of the impression, and that if the patient is feeling uncomfortable, like they're going to gag, they can lean forward. That way it doesn't feel like it's going towards the back of the throat. The mandibular doesn't typically tend to be as uncomfortable as the maxillary. When you go to remove it, you might have to pop loose the suction. Don't panic. It's not stuck in there. Just pull up from the gum line and evaluate your impression to make sure that all the teeth are present. You didn't hit the tray. It's nice and centered. That way you can take it back to the lab. If you're not going to immediately pour it up, wrap it in a damp paper towel and place it into a lab bin with the patient's name. Now we're going to mix up our maxillary impression. Again, centering it, pressing from the back to the front, making sure that the lip is out and over top of the impression. Continually keep this in place until it's time to pop it loose. After you've gotten both of your impressions, now it's time to move into the lab. And honestly, I think this is a lot of fun. It's very artsy. And there are specific measurements, so many grams to so many milliliters of water of this stone material. And stone is a plaster material. We get it from gypsum. It's a mineral that we mine from the earth. But we really just kind of eyeball it for the mix that we want. We're going to get a Dixie cup full of stone and slowly add water in. The nice thing is if you do add a little bit too much water, you can add more powder to it. If you don't add enough water, so it's really dry, you can add more water to it. The consistency that I personally like to go for is more of like a frosting consistency. Some people like there's a little bit thinner. Some people like there's a little bit thicker. The main point is at the end, we should have a bubble-free product. There shouldn't be air voids in that final 3D rendering of the patient's mouth. You want to place your disinfected, so you're going to spray it with a disinfectant, impression onto what we call the vibrator. It's a machine that's going to vibrate that material and slowly, little by little, add that stone material into one area of the alginate impression, tipping and turning it and allowing it to flow through those teeth. Vibrate all of the liquid out, all the air bubbles out. Once you've vibrated that completely out, then you can start adding more of that stone material to the top. Now this assistant here likes their material thinner than I personally like to. It is a preference thing. So as long as that final product is void free, you have a nice thick base, then it doesn't really matter if it's a little thinner or a little bit thicker. The reason I don't like it so thin is because when I do invert it for what we call the inverted technique, it tends to kind of slop out of the sides of the base plate. There are different products. This is a lab stone. It's a buff stone, rather. There are different ones that set up quicker. They're maybe more dense. If you're in an ortho office, you might be using what's called plaster. It's made from the same gypsum, but it's a lot finer. It's got that pretty white look to it. The crystals in it are going to form more uniformly, and that way it's prettier, it's smoother, but it's a lot softer. So you would drop a plaster model and it basically would break apart into pieces, whereas a stone model, you'll drop it, and most of the time it's just going to bounce onto the floor. Now we're going to take our excess material and we're going to put it onto our base plate. I like to put a little doggy pile right in the center of that base plate there. You may not have a lot extra. This is going to be something that you're going to have to practice and get better at as you go.
We're going to start by wearing the proper PPEs, which would be eyewear protection. We're going to remove the alginate impression from the stone model. Usually this peels off rather easily, but if it doesn't, you can use a lab knife, place it underneath the impression, twist like a key, and pop it off. If you are pulling off this impression as soon as it is set, you will not have to pick off the alginate and it be hard as you see in the video. It would normally be still a really soft and pliable material. This is the model that has sat for a little too long. You don't want to let it sit for too long because when you're pulling this off, you risk breaking the teeth. But we see that there are no broken teeth, no air bubbles, so we're going to clear off our model trimmers. We're going to rest it flat on the platform, and we're going to reach back and turn on the water and the trimmer, which are typically located towards the back of the trimmer itself. We want to make sure that the water's on but not too high where it's spraying all over the place. You'll notice if you don't have enough water, your trimmer itself will end up turning kind of a yellowish color using the stone. Keeping the model flat on the platform, we're going to press it against pressing with force against the rotating wheel. And we're going to start trimming off the most posterior region of this model. This model has a lot of overhang on it that we want to reduce, whether it be for study cast, to go over treatment with a patient, or to fabricate inside a lab. It's just going to be in the way. So we're going to keep pressing as we're going. You'll notice it starts to become really flat on the edges. Make sure you're never holding it up off the platform or it starts to kind of jump around on you. We're going to go around the edges, refining that, making it more aesthetically pleasing and a little bit easier to fabricate onto. So we're keeping it flat on the platform, constant pressure, making sure our fingers are clear of the spinning wheel. We're also going to be careful that we don't trim too close to the teeth themselves, but you'll notice that it's looking a lot better. You can see the anatomy, you can see the vestibular area, so we're going to continue through removing the excess material. You'll notice that pieces of the stone do fly, so eye protection is a must. A lot of trimmers do come with shields, these plastic protective covers essentially that go over top of the platform that would help prevent that stuff from flinging up toward your face. There's still a good amount of overhang left around this, so sometimes it might be thin enough we can just pop off, but it's not. So we're going to go through and finish up cleaning this up. So I just keep a nice smooth rounding motion as I go. Be careful not to press your model too far against the trimmer, because then what ends up happening is you start to trim away portions of the teeth. As you can see, these buccal portions have been trimmed away. And when we're fabricating things, it doesn't work for what we want. The last trim that we're going to do, we're going to make sure our fingers are away from the trimmer. We're going to keep that flat portion that we trimmed first flat in the platform, and we're going to press against the wheel. What we're doing is we're reducing the height of this platform, which in a lot of lab cases, you don't need to do this. So if we're mounting them for a denture case or anything like that, this wouldn't be needed. But since we're going to be fabricating whitening trays from this model, we actually want to create a little air gap. We want to make sure that when we're vacuum forming the material to the model, it's able to suction the air from the lingual surfaces. So that's what we're doing now. This may take you a while if you have a really thick base, but eventually you'll end up getting a hole in the palate or the lingual portions. When you're done, make sure that you shut off your trimmer. Anytime you walk away from it, it needs to be shut off, and shut off your water to prevent flooding the area. We're going to take off the platform and clean it. This is part of the routine maintenance, that when you're done with your trimmer, you should remove your platform. Now our sink has a special trap underneath it to prevent that stone from building up in the city plumbing, but we still want to get any chunks out of the sink to make sure it stays clean. You'll notice that there are still chunks in the trimmer itself, so we're going to just rinse it down with just some regular sink water. Replace our cleaned platform. And you're all set.
To fabricate the whitening trays, now we'll take our whitening tray material, which is a really soft, pliable material that usually has a protective film so it doesn't become discolorated and stick to the other material in shipping. Peel out that outer film and place it into your suck down machine. Latch that suck down machine into place, raise up the frame and tighten it with the two black knobs on the back, and place your model teeth side up in the center of the perforated platform. Here's a different view of that. After that material has heated and is soft and pliable, you'll drop the frame down to the mouth and you'll flip the switch to the right to suck it down. And that's going to be about 10 seconds that it's going to suck down. After you remove it from the frame, be careful not to pull on and distort the tray itself. You're going to want to wait about 10 minutes or so before you pop it out, otherwise it'll stretch and distort. Once it's cooled, you can pop it out of the model, give the patient their model so if they ever need to have their whitening trays remade, they don't have to redo the whole impression and model, and it saves them some time, money, and honestly just being comfortable. Unlike retainers or mouth guards, you can easily just cut this with a pair of tissue scissors. You'll go around the excess just to get it out of your way. Cut along the lingual surfaces of the tooth. Then lastly, scallop around the edges of the buccals and facials. We have two finished products. The one here does not have blockout, but the one with the blue has blockout, which is an added material that you can put onto the model that creates like a pocket for the whitening gel to sit into, which is not necessary, but some offices like to do that for their patients. You'll then send your patient home with a set of whitening gel that they'll place a small pin drop into the fronts of the teeth that they want to whiten. There are other options like pre-filled whitening trays, in-office Zoom whitening that utilizes a bright light that's going to work with a gel that's applied directly to the teeth. Usually you have to use like this special retraction material that goes around the gums to create a brighter, wider smile. As you gain years of experience as a dental assistant, you'll attain mass amounts of knowledge from different coworkers and employers. And at some point, you will feel quite confident in your skills and abilities, and one being the ability to recognize common dental issues. Oral pathology is the study of diseases in the oral cavity, and only a dentist or physician can diagnose pathological conditions. So even though you might recognize it, you cannot diagnose it. Our ability to recognize the difference between normal and abnormal conditions will help aid in patient care, so we can bring certain things of concern to the attention of the dentist and prepare necessary items for that treatment. If you've ever had fever blisters or cold sores in your mouth, you know how annoying those can be. What that actually is the herpes simplex virus type 1, HSV1, infected on the tissue there. It's highly contagious and so common that according to the Cleveland Clinic, over half of the U.S. population has HSV1. It can be spread through saliva, by sharing utensils, lip balm, kissing. It can even be spread from skin to skin contact, and you do not need to be showing symptoms to spread it. The symptoms tend to be most noticeable when it's first contracted, and those include tingling, burning, itching on or around your lips, red, swollen, and painful blisters on the lips, face, or tongue. They can appear anywhere on your skin and even inside of your mouth. It's best if we reschedule these patients that have these active lesions because the virus can travel via aerosol created during our dental procedures. And if it gets into our eyes in severe cases, it can actually cause blindness. So, what could we do to protect ourselves? Well, a great way is to wear protective eyewear. That's a barrier to protect our eyes. Oral thrush is a fungal overgrowth that can cause uncomfortable red bumps and white patches inside your mouth. The treatment would include addressing the health condition that would have caused it, as well as the use of antifungal medication. You have an increased risk of oral thrush if you have diabetes, a weakened immune system, if you wear dentures, or any other condition that causes dry mouth. If you take certain medications like prednisone, inhaled corticosteroids, or antibiotics that disturb the natural balance of these microorganisms in your body. According to the CDC, oral thrush is the most common fungal infection there is, and other symptoms might be loss of taste, pain when eating or swallowing, cracking redness at the corners of your mouth, and it can be noticed throughout the oral cavity, including the uvula as pictured here. Black hairy tongue is a condition that is exactly what it sounds like. It causes your tongue to look like it's growing black hair. But don't worry, it's not. What actually happens is that dead skin cells collect on the papillae, which are the small bumps formed by the mucous membrane cells that make up the tongue surface. And what this does is it makes them longer than normal. Most of them are only about 1 millimeter long, according to the American Academy of Oral Medicine. The long papillae are actually more easily stained by things that you consume, causing that black coloring. Some symptoms you might have is change in taste, bad breath, can cause a gagging sensation. And although it doesn't sound like much fun, the good news is it is harmless. It's easily taken care of by getting rid of possible contributing factors like smoking and increasing good oral hygiene. In 2021, the American Cancer Society estimated the prevalence of oral cancers to be about 54,000 cases and about over 10,000 deaths for a year. The primary cause is HPV, followed by smoking and heavy alcohol consumption. So there is a significant portion of oral cancers that are most likely preventable. According to the World Health Organization, 30 to 50% of all cancers are most likely preventable by doing these things, which you can find on their website. Avoiding tobacco products, drinking alcohol in moderation, limiting processed meats in your diet, maintaining a healthy weight, not sharing needles, performing self-exams, visiting your doctor and dentist, and practicing good oral hygiene. Patients really should not wait till their last appointment to have any concerns that they have to new bumps, discoloration, and lesions because these may be early signs of cancer. If there's anything that changes, they need to come in for like a limited exam to take a look at what's going on. What some of the pathology that you'll see in dentistry has in common with this section is that it can be caused by a microorganism. Microbiology itself is the study of an organism that can be seen only through a microscope. This includes bacteria, algae, protozoa, and fungi. And although viruses are not considered living organisms, a lot of times they are lumped in with microorganisms. The study of viruses, though, specifically is called virology. In dentistry, microorganisms are encountered throughout everything we do and can include pathogenic, disease-causing microorganisms or non-pathogenic ones that cannot cause human disease. Microorganisms can live on environmental surfaces for sometimes up to weeks, so we should always assume their presence and practice good infection control. Microbiology came into being largely through studies of bacteria, through the experiments of Louis Pasteur in France and Robert Koch in Germany, and others in the late 1800s who established the importance of microbes to humans. Even in the late 1800s, there was a lot of studies going on with microorganisms. And one of the topics that is heavily studied is morphology. Morphology refers to the size, shape, and arrangement of cells. The observation of microbial cells requires not only microscopes, but also the preparation of these cells in a way that's appropriate for that type of microscopy. During the first decades of the 20th century, the compound light microscope was the instrument that was commonly used in microbiology. They usually have about 1,000x and a maximum magnification of about 2,000x. These specimens can be observed either after they've been stained by one of the techniques to highlight some of their morphological characteristics, or in living unstained preparations such as a wet mount. There's been several modifications of light microscopy available, such as bright field, and this is where the specimen is usually stained and observed while illuminated. This is extremely useful for the observation of gross morphological features of the bacteria, fungi, algae, and protozoa. Dark field microscopy is where a specimen is suspended in a liquid on a special slide and can be observed in a living condition, useful for determining motility of microorganisms or some kind of special characteristics such as spiral or coiled shapes. You have fluorescence, where the specimen is stained with a fluorescent dye and then illuminated, and it'll take up that dye and basically glow. A phase contrast that uses condenser lenses to help us see the different varying densities. With the development of the electron microscope and other techniques, it's vastly increased the power beyond those attainable with light microscopes. This is because the wavelengths of the electron beams are so much shorter than the wavelengths of light, and objects as 0.02 nanometers are resolved by electron microscopes. You can see really, really small objects. When we talk about germs, generally we're talking about bacteria and viruses kind of lumped together. Bacteria are usually broken into what we call prokaryotic or eukaryotic. And what makes these different from each other is that a nucleus and other membrane-bound organelles are only present in the eukaryotic cells, whereas prokaryotic cells don't have that. They lack that. All bacteria are prokaryotic. They're single-celled organisms without that membrane-bound nucleus. Their DNA, which is the genetic material of the cell, instead of being contained in that nucleus, exists as these long, folded, thread-like things with no specific location within the cell. Bacteria come in a variety of shapes, including spheres, rods, and spirals, and although is an external whip-like structure that propels the organism through any kind of liquid medium. Dental infections that originate in the tooth or its supporting structures can actually spread to surrounding tissues, and these infections most commonly occur when bacteria invade the pulp and spread to surrounding tissues. They can affect the gums, gingivitis, and can lead to periodontal disease. Tooth decay specifically is caused by the bacteria mutans Streptococcus. common foods like chips, rice, those all break down into glucose in your body. So the more sugar you consume throughout the day, the more the acid the bacteria produces, which can lead to further decay. What are mouth infection symptoms? Sores, bad breath, pain, tooth sensitivity, bleeding gums, swelling of the gums or lymph nodes. So it really is best for a patient to be evaluated prior to prescribing medications so that we're not overprescribing antibiotics when this issue could be viral, because antibiotics will not help against viral infections, only bacterial. They are single-celled, you can see them linked together in chains, pairs, or even clusters. Some of them even have what's called a flagella, which love sugary, sticky foods, and that includes your carbohydrates, which now you may be asking yourself, when would we ever be dealing with algae in the dental realm? Well, really that's pretty isolated to the dental unit water lines, because these are dark, moist environments that bacteria and algae can kind of harbor in. What algae is a microorganism that collectively, with protozoa and some other fungus, are frequently referred to as protists, the kingdom Protista. Some are unicellular, others are multicellular, and when it comes to the dental unit water lines, all practices should properly and regularly maintain their dental unit water lines as a part of their regular infection control protocols. While the infection caused by contaminated water lines are rare, especially with a healthy patient, but with patients like the elderly and ones that have compromised immune systems, they may be more susceptible to infection from these water lines if they're not properly maintained, because they can harbor so many different microorganisms that can multiply inside of the tubing, resulting in that biofilm. We have to be careful and mindful to take care of all those different little steps. Unlike bacteria, algae are eukaryotes, and like plants, contain a green pigment called chlorophyll and carry out a process called photosynthesis. They typically occur in moist soil and aquatic environments, but these multicellular organisms that can appear in a variety of forms and degrees of complexity are things that we have to be aware of and be mindful of. Fungi are eukaryotic organisms that, like algae, have rigid cell walls and may be unicellular, having one cell, or multicellular, having many. Some may be microscopic in size, while others form much larger structures, such as mushrooms and bracket fungi that grow in soil or on damp logs. But, unlike algae, they do not contain chlorophyll and cannot carry out photosynthesis. They don't ingest food, but they do need to absorb dissolved nutrients from their environment. Those that are multicellular can frequently cause mold, whereas you have yeast that is unicellular. And with that, it causes thrush by the overgrowth of that naturally occurring yeast in the mouth. It's an opportunistic pathogenic yeast that's a common member of the human gut flora, so it's natural part of the human body, and thankfully is treated through antifungal medications. Some things like antibiotics, chemotherapy, and radiation can actually trigger these outbreaks, and they have that common symptom of that white curd-like plaque on the inner cheeks, tongue, roof of the mouth, back of the throat. People that have HIV are actually at a higher risk of developing thrush, and you will see this in little babies, and it causing some discomfort for them. Protozoa are single-celled eukaryotic microorganisms. Some protozoa are oval or spherical, others are elongated. They all have different shapes and sometimes even depending on their stages of their life cycle. They sometimes can be as small as 1 micron, which is equal to 1 millionth of a meter, to as large as 2,000 microns or 2 millimeters, which these are actually visible without magnification. And like animal cells, protozoa lack cell walls and are actually able to move at some stage of their life cycle. They ingest particles of food, with some of them actually obtaining their energy through photosynthesis, like plants. Protozoan cells contain the typical internal structures of an animal cell, with some of them actually being able to swim through water. The amoebas do not swim, but they can creep along surfaces, extending a portion of themselves as a pseudopod. So think of them like stretching out an arm and pulling themselves up, and stretching out and pulling themselves up. It's kind of a form of locomotion. Toxoplasmosis is a parasitic disease caused by a protozoan. It usually manifests through the enlargement of a lymph node and the appearance of antibodies in the saliva. So you may be running a saliva test if you thought that a patient in a medical setting, not the dental setting, might have toxoplasmosis. It is typically spread by eating poorly cooked foods that contain the cyst. It can be from exposure to infected cat feces or even from an infected woman to her baby during pregnancy. So a lot of times women that own cats while pregnant are advised not to change the litter box or to do so with extreme caution. That way they don't get sick. Rarely it may be spread by a blood transfusion or other organ transplants, but otherwise it's not spread from person to person. Entamoeba gingivalis is a non-pathogenic amoeba that actually inhabits the human oral cavity and occasionally other parts of the body. It's generally considered a commensal in the oral cavity. While it's been associated with certain clinical conditions such as periodontitis, its presence is really not understood. It's generally considered incidental in the cases that there are other oral conditions going on. They believe that the amoeba is probably feeding on the bacteria associated with those other conditions. So generally, the Entamoeba gingivalis is non-harmful to the human, but toxoplasmosis obviously is. Previously mentioned, if we're talking about germs, usually we're lumping together bacteria and viruses. And even though viruses aren't actually a living organism, they get lumped in there with them. Viruses are studied through their own specific category of virology. Viruses are considered like on the borderline. They're included in the science of microbiology because they come in several shapes, are widely distributed in nature. They infect animal cells, plant cells, and microorganisms. They are considered obligate parasites, meaning they lack the metabolic machinery to generate themselves energy or to synthesize proteins. So they actually have to rely on that host cell that they infect to carry out those functions for them. So they hijack that other cell and use its ability to create energy and multiply to further their purpose, basically. Hand, foot, and mouth is a viral infection in the mouth and other parts of the body that typically you're going to see toddlers and school-age children having. And according to the University of Chicago, it is likely caused by the virus Coxsackie A16. It sounds really scary, but the infection actually disappears typically within 3 days. It is uncomfortable. You've got sore throat, fever, slightly painful blisters inside the cheek, on the tongue, and on the palms, sores of the feet, and even sometimes on the buttocks is where you can see hand, foot, and mouth kind of manifesting. Herpangina is an infection in the mouth, and it is actually closely related to hand, foot, and mouth disease because the typical first symptoms include fever, sore throat, and difficulty swallowing. But these symptoms are actually closely followed by blisters in the back of the mouth, and they can form large ulcers when they burst. Usually you're going to see children aged 3 to 10 during the summer and fall season, and this is going to last a little bit longer, about 3 to 5 days. With HIV remaining a global public health issue, it's estimated to have claimed 42.3 million lives. It is transmitted through the blood. There's no cure for it, but because of ever-improving medical care, there are treatments available that help those that are HIV infected to have a more manageable chronic health condition. It allows them to live a longer, more healthy life because HIV, the human immunodeficiency virus, attacks the immune system and actually develops the acquired immunodeficiency syndrome, or AIDS, in the more advanced stages of the infection. The way that it works is it targets and attacks the white blood cells that weaken then the immune system of the body and makes it easier for that person to get sick with diseases like tuberculosis, infections, even some cancers, and spread by the bodily fluids of an infected person, including blood, breast milk, semen, and vaginal fluids. And it's not spread by kisses. There's always this concern of that. Hugs. It can be spread from a mother to her baby, but it can also be prevented by treating them with an antiretroviral therapy during pregnancy. Another virus that you're probably used to hearing is hepatitis, because we in the dental field inoculate or get a vaccine for hepatitis B. Hepatitis, there are a few different kinds of it. There's 5 main types: A, B, C, D, and E. It causes inflammation of the liver. It can be self-limiting, or it can progress to fibrosis, which is scarring, and cirrhosis, or liver cancer. Of the top 5, the greatest concerns are going to be B and C, because they lead to chronic disease, and they've done that for hundreds of millions of people and are together the most common cause of liver cirrhosis and liver cancer. Hepatitis A and E are typically caused by ingesting contaminated food or water, and with B, C, and D, those can be a result of contact with infected bodily fluids through like a needle stick injury. Common modes for these viruses include contaminated blood or blood products, invasive medical procedures using contaminated equipment, and transmission from mother to baby at birth. The acute infection may occur with limited or no symptoms, but it can cause jaundice, which is yellowing of the skin and eyes, dark urine, fatigue, nausea, vomiting, abdominal pain. So when it comes to any of the microorganisms that we come into contact with, the bacteria and the viruses are the ones that typically raise up our red flags a little bit more. We're more concerned and aware of their presences. But when we are following proper infection control protocols, wearing our PPEs, disinfecting our rooms, sterilizing our instruments, doing all the things that we're supposed to do to have that high clinical excellence, we as a staff member shouldn't have to worry or be scared that we're working on a patient that we know has an active viral infection like HIV, because we're treating every patient with what we call universal precautions or standard precautions. Everyone's bodily fluids are potentially infectious. I don't want you to go into your new career being scared that you might contract something. I don't think that I've ever been scared in my years of working as a dental assistant. I've just been aware and been cautious enough to make sure that I'm protected and that I'm not bringing any contaminated clothing home to my family. You know, I've got different scrubs or clothes to change into at the end of work. I launder my clothes separately from the rest. The shoes that I wear at work are not the shoes that I wear at home. I shower when I get home because I want to make sure I'm protecting myself and my loved ones. But not too long. Another virus that is going to affect the oral cavity is going to be oral herpes. These can cause outbreaks of these fluid-filled blisters inside of the mouth or on the lips that can last for a week up to 10 days. And when they blister, they're going to scab over, and that's when there's no pain. And it's caused by the herpes simplex virus. But this is contagious, so we want to make sure that we're being careful around our patients that have any kind of like visible outbreak of it. The coronavirus, COVID-19, a lot of us know oh too well, is an infectious disease that is caused by SARS-CoV-2. Most people infected will experience mild to moderate respiratory illnesses and usually recover without any kind of special treatment, having like a more severe flu-like symptoms. However, some can become seriously ill and require medical attention, depending on whether or not they are already immunocompromised. With HIV remaining a major global public health issue, it's claimed that it's estimated so common that up to 4 out of 5 adults in the U.S. actually have the oral herpes virus that they carry with them. It can, in some cases, cause flu-like symptoms and ulcers on the gums and tongue, but a lot of times there may not even be any symptoms at all. And once infected, this virus will actually remain in the body for the rest of the organism's life. Still, the infection-causing sores can stay dormant with proper care. Prions are probably something that you don't really hear discussed really all that much. They are actually smaller than viruses and are the simplest of infectious agents. Similar to viruses, they are obligate parasites, meaning that they don't have any genetic material and aren't able to produce their own proteins or their own energy, so they have to rely on the cells of the other organism. They are linked to causing various diseases, including certain encephalopathies like scrapie, which is in sheep and goats, chronic wasting disease in deer, and then mad cow disease, the bovine encephalopathy. It can cause, I cannot pronounce this, the Creutzfeldt-Jakob disease in humans, which affects the nervous systems of the mammals. And although the exact mechanism for transmission isn't quite known, it's thought to be due to an infectious protein or protein-like substance. This disease is considered rare and fatal to humans, and intense regulatory efforts have been put into place to make sure that there's no possibility of infected materials like infected beef is not making its way onto the shelves. So certainly this isn't something that you're going to necessarily be in contact with or as conscious of in the dental realm, because it doesn't really apply to what we're doing, but these do exist. Lichen are a really kind of cool topic. They aren't just a single organism. What they are is a symbiotic relationship between two different organisms where they're both benefiting. It usually consists of a photosynthetic microbe like algae or cyanobacterium, creating a relationship with a fungus. Usually it has a top layer with tightly woven fungal mycelium, a middle layer where the photosynthetic microbe live, and then a bottom layer of mycelium. The way that this works is that the photosynthetic microbe synthesizes nutrients for the fungus, and in return, the fungus actually provides protective cover for the algae or the cyanobacteria. They play a really important ecological role as they are able to transform rock to soil. Humans can use them for creating dyes for clothing and decoration, but did you know that people also eat them? I didn't really know that until I was doing some research on it. And in some times of hardship, certain cultures will actually eat this, while other times it's sought out all the time. But this isn't saying go out and just peel this off a tree and eat it, because not all lichens are edible. In fact, some can be poisonous. For example, the wolf lichen got its name because it actually was used in Europe to poison wolves. ground lichen was actually determined to be the cause of death for about 300 elk in Wyoming in 2004. But that same lichen can also be used as a dye for clothing. Sometimes they are used in the creation of deodorant, toothpaste, salves, extracts, perfume, and others are actually being researched for their antibiotic properties. So they may have a beneficial purpose when it comes to the antibiotics that we're prescribing to our patients. Many of you are going to recall the year of 2020 with the COVID-19 pandemic and how the idea of universal or standard precautions was being spoken and practiced by the masses. Now, prior to that year, the general public may or may not have paid much attention to the idea that everyone around us could be potentially carrying an infectious microorganism, and that the idea of is if it's wet and not yours, you should be treating it as potentially infected. The standard precaution applies to all bodily fluids and secretions except for sweat. And I don't want you walking around being scared because there are some things that we can do on the daily basis in our everyday lives and when working with our dental patients to keep ourselves healthy. In the dental practice, there are certain laws and regulations that we must adhere to protect ourselves and our patients. And a lot of times this is regulated by OSHA, the Occupational Safety and Health Administration. Their idea is to protect employees, and failure to comply to them actually can result in hefty fines. They developed what we call the bloodborne pathogen standard, which arguably is the most important infection control law in dentistry. It's designed to protect the employee against occupational exposure to bloodborne pathogens like hepatitis B and HIV. What the law does is it requires that there's a copy of the bloodborne pathogen standard to be present in the dental office and outlines how we're going to protect our employees, what are our standards with infected, say, gauze that is blood soaked and you could wring the blood out. That should be going into your biohazard bag or into a sharps container. Where do the needles and sharps go? They go into your red, non-puncturable biohazard container. It's also a requirement that an employer offers the hepatitis B vaccine at no cost to all employees that are hired within 10 days of their hire. The employee does have the right to refuse it, but must sign a medical release form stating so. It is effective for at least 15 years and is noted safe for pregnant women to have. We in the dental field are at a higher risk of contracting it because we're in a daily contact with blood and saliva. And because accidents do happen within your binder, you have what's called an OSHA binder, there should be a written exposure plan or written plan that outlines what should be done post-exposure. So there should be medical follow-ups as anytime there is an exposure incident, and this should be provided at no cost to the employee. All staff must be properly trained in infection control protocols, and records of these trainings should be kept on file while the employee is working there and for about 30 years after their last day of employment. Medical records should be kept on all staff members, and every staff member should be trained on the hazard communication standard, which requires the employer to inform us as the employee about different hazards that we're going to be in contact in the workplace. We know this as the Employee Right to Know law. This standard is broken into 5 parts: the written program, the inventory of hazardous chemicals, the SDS sheets for each chemical, and then proper labeling of containers and employee training. If I were to take a material and remove it from its original container to a unlabeled container, I would have to properly label that new container, even if it's like I bought a bulk container of Windex and I'm putting it in a small spray bottle. I have to properly label that spray bottle so there's no confusion as to what it is, or if it came into contact with skin or eyes, then we would know how to properly handle that exposure. OSHA would be considered a regulatory agency because their rules are having to be adhered to, or fines and consequences like the loss of licensure can follow. Whereas advisory agencies such as the CDC can only make recommendations. They make them based off of their scientific evidence, but don't have any legal authority like the advisory agencies possess. Even though advisory agencies possess no legal power, their scientific suggestions are taken under consideration of regulatory agencies such as OSHA, and regulations are based off of said research. The CDC's main role is protecting the health of the public. The FDA will regulate the manufacturing and labeling of our medical devices, and in dentistry, they're going to approve our sterilizers, biological and chemical indicators, cleaning solutions, gloves, masks, eyewear, and dental handpieces. The EPA is going to ensure that our disinfectants are effective but also safe to use. OSHA can come in for an inspection, but usually you're not going to have OSHA coming in for an inspection because a lot of offices don't meet the parameters of having 11 or more employees. It can occur when a complaint is made, or if the dentist asks for a consult for them to come in to make sure that they're maintaining proper training and documentation so that no fines would occur. The spread of infection within a community is described as a chain, these interconnected steps that tell us how a pathogen moves about throughout the community. And if we are able to break one link of that chain, then we break the spread of infection. First off, a microorganism has to be capable of spreading infection to humans, known as a pathogen. They have to have a reservoir. They have to have a optimal growing condition, which is going to vary from each microorganism to the next. Like, aerobic organisms have to have the presence of oxygen, where anaerobic organisms need the absence of oxygen. The pH, temperature, and location are all necessary things that the reservoir must have. Then, once the microorganism has a port of exit available, it can spread via airborne particles from sneezes, coughs, directly with bodily fluids, vectors, which are organisms that spread infection from an animal to a human or from one human to another, like mosquitoes carrying malaria or ticks carrying Lyme disease. And if there's no port of entry, then the potential host is actually safe from infection. Depending on the microorganism, they require specific ports of entry as they target specific cells of the body. A good way to break the chain of infection at this step is by properly washing hands, not touching your face and mouth, and washing your hands before you put on gloves and immediately after taking them off is a good clinical infection control practice. Preventing things like Lyme disease is using bug spray that contains DEET, or even just checking yourself over to make sure that you get those bugs off you before you end up with a bite. The interesting thing about Lyme disease is that it doesn't necessarily cause an immediate problem. And sometimes that telltale bullseye that we're looking for in a patient who is infected with Lyme disease is not even present in some cases. And the symptoms might be showing up 2 weeks after the initial bite with Lyme arthritis, where there's inflammation of the larger joints, a lot of times the knees, really painful, and is diagnosed through an x-ray, but more importantly, a blood test. Should the microorganism make its way into the potential host, they must also be susceptible. Having a healthy lifestyle can help greatly reduce the chance of becoming ill, or at least extremely ill, from pathogens, because some pathogens can even get the healthiest person sick in a moment of immunodecompression. The young, the elderly, the immunocompromised and malnourished would be considered our at-risk populations. Based on the concept that all human blood and bodily fluids are to be treated as if known to be infected, everyone should follow the same standards no matter who's in the chair. You cannot simply look at someone and know for certain if they're carrying a pathogen that you could become infected with. Following standard precautions, using proper PPEs, safe sharps handling water line maintenance. These are all ways that we can prevent the spread of infection in our dental office. Vaccines are going to be to protect ourselves. But before we can understand how vaccines work, we need to first understand how our immune system actually works. It is a network of different tissues and organs that work together to defend our body against harmful pathogens like bacteria and viruses. When they get into our body, they're going to multiply and attack, creating what we call our infection that makes us sick. The immune system is like the guard system of your body. They're always on patrol. They're scanning and looking around, and when they come across an invading bacteria, virus, or other microorganism, it's going to attack, causing an immune response. It sounds this alarm by releasing antibodies, and these are like our soldiers that are designed to fight off that specific microorganism. And this can take a few days for it to happen, but they attack and weaken to destroy the microorganism. Afterwards, your immune system then remembers it, and if it were to invade your body again, it'll quickly recognize it, send out the right antibodies to help keep you from getting sick. When your immune system is working properly, it'll be able to tell the difference between cells that are yours and ones that don't belong. But there are different conditions that can weaken our immune system and make us more susceptible. Conditions at birth are less common than those that develop later in life, like type 2 diabetes and cancer. And at the other end of the spectrum, you could have an overactive immune system that reacts too strongly to these, where they mount an attack when there's no invader, or they keep attacking after they've gotten rid of the microorganism, and can cause issues with autoimmune diseases and even allergic reactions. White blood cells, antibodies, cytokines, lymph nodes, the spleen, the thymus, tonsils and adenoids, bone marrow, even your skin are all ways that your body are able to protect themselves against these. When you have acquired immunity, this is when you've been in contact with it, your body has the antibodies, and now you have immunity for life. Artificial immunity is when we use a vaccine to artificially, air quotations here, infect the body. So these are either live or non-live germs that allow your immune system to then create the antibodies to these weak or deadened germs. Another way that we can help prevent the spread of infection in the dental office is proper disposal of waste. General waste is going to be our paper towels, mixing pads, patient bibs that are placed into the regular waste bin. They don't have special regulations. But contaminated waste has been in contact with blood and other bodily fluids, and as long as it's not blood soaked, these also can be put into your regular waste bins. When it is blood soaked or has a toxic chemical like scrap amalgam, fixer solutions, this is considered hazardous waste, and your state is going to mandate how these need to be properly disposed of. Infectious waste is going to be biohazardous waste, capable of transmitting infectious disease and has to be disposed of in that biohazard container. The pathogen must be strong enough and in large enough numbers to infect a susceptible individual, but we still want to practice good rule of thumb that if you can wring it out like a wet washcloth, put it in the biohazardous waste. But if it has a just small drop of blood, this can be disposed of in the general waste. Extracted teeth, soft tissues, sharps, and scalpel blades are also considered biohazardous, but they are also sharps, so they have to be in an actual sharps container, the non-puncturable, closable, red, leak-proof container. They should be being kept as close to the place of immediate disposal, meaning there should be one in each operatory and in the sterilization area. And then when it's time to start working, we're going to don our PPEs, our personal protective equipment. I like to put them on from head down. So our eyewear, our mask, making sure that we're putting it on properly, bending it at the nose, placing it over your ears without looping them. When you loop them, what happens is you actually get like this bunch on the side of it, and pull it down under your chin and fold it around your nose. So you've got your eyewear, your mask, and your gloves last. Now the gloves are really important that you have ones that fit and function, so make sure you're wearing the proper size gloves. If they're too big, then you lose dexterity, and if they're too small, they can rip really easily. So eye, mask, gloves last. And now that you're completely done, if you need to doff your PPEs, make sure that you're doing properly so that you do not contaminate yourself or anything around you. Remove your mask and your gloves. Wash your hands and eyewear. Woot, woot, you did it again. Woot, woot. Good job. You've made it through another training. So let's review some of the new learned skills that maybe were a little bit more challenging.
The following training video is a composite procedure video designed to help the dental assistant to better understand the general steps of most composite filling procedures. This is not to take place of going to dental school or getting your training as an EFTA. It is simply to help you understand what typically occurs during a composite procedure appointment. Prior to the procedure being performed, the treatment would have been treatment plan documented in the chart. The treatment plan and cost would have gone over with the patient, and they would have accepted this treatment and cost and schedule. When you are looking at your schedule for the day, you'll confirm with their treatment plan that that's truly what needs to be done. From there, you're also going to be evaluating their medical history to see what type of anesthetic can you set up. For each patient, you're going to want to make sure that you have topical anesthetic, and you don't need a lot of it. Just a little goes a long way. And you're going to want to set up your syringe, your aspirating anesthetic syringe. Now, when determining what type of needle you're going to be using, this is going to be based off of the area of the mouth you're working on. So if you're working on an anterior or a maxillary tooth, typically your doctor is going to use a blue short needle. If you're working on a posterior mandibular, then typically they're going to be working with the yellow long needle so that they can perform a block injection. Purple needles are used particularly for pediatrics or really small mouths, but some doctors I've seen use only yellows, so it kind of is just a lot of times preference at that point. As you're assembling it, you're going to want to make sure that you take the hub end of the needle off first. This is what I like to stick my topical anesthetic into so that it doesn't get everything else sticky. So I like to stick that right in there and off to the side. Then you're going to take your anesthetic syringe and you're going to line up the needle with the threaded tip, screwing it on, making sure not to over tighten it, otherwise it becomes problematic and that threaded tip tends to come off with the needle. Next, what you're going to do is you're going to determine if the anesthetic that you have, the Carpul, is the correct medication. If they are a heart patient, if they've had any adverse reactions, or they're pregnant, you're going to want to avoid an anesthetic that lists epinephrine as a ingredient. Check the expiration, make sure it's not expired, it's not broken, showing air bubbles or use, or any kind of discoloration, and no puncture marks on the top like this training one is. We're going to put in the rubber stopper in first by pulling back on the piston and the thumb ring, like so. You'll see the harpoon disappears down into it. We're going to place it in, line it up, and gently slide it into place. Firmly grab that syringe and give it a nice firm spank at the end to engage the harpoon into the rubber stopper. And we're going to leave this capped for the doctor so that they can give the injections. When it's time to perform the procedure, the dental assistant may place topical anesthetic in the gum area close to where the injection will be needed. So on a maxillary tooth, they typically are doing what's called an infiltration injection. So the topical will be placed right near the apex of whatever tooth you're working on. If this were mandibular, I would place it near the tooth we're working on both the buccal and the lingual, but also back in the block injection area. And it'll take a couple minutes for it to soak in, to which the doctor's going to come in, give the local injection or the shot, and we'll start the procedure. In a composite filling procedure, especially on anterior teeth, it's extremely important that we get an accurate shade match. Last thing we'd want for our patients to do is walk out with a shade that looks nothing like their natural teeth. You'd want to make sure that you do this under natural light, so the operatory light will be turned away prior to, preferably before drilling on the tooth and even before the anesthetic if possible. Once you find a shade that you like, then on each tab, there will be a shade that's listed, and that will coincide with all the composite materials that you're going to be using. During the prep part of the procedure, this is where the doctor will be utilizing their high-speed and slow-speed handpieces. You'll have your HV suction placed to make sure that all that tooth debris and aerosol are getting caught by that. And then we're going to isolate the tooth. Cotton rolls, 2x2s, dry angles, all these cottons are used in basically every procedure, so these are a given that they're going to be out and ready to be used. After the tooth is isolated, the steps are very similar to that of a sealant, which you'll start off by passing over the syringe of the etch to the doctor underneath the patient's chin in the position of use so they can grab and go. You're going to syringe this on all the prepared surfaces. We call this a prepped tooth. And that's going to sit there for about 30 seconds, to which you then are going to rinse and suction it away. When this 30 seconds is occurring, you can already have your HV and your air water syringe ready because you know that that's going to be there. You should be anticipating your needs. And the more that you work with the doctor, the easier this becomes. Tooth is thoroughly dry because this is a chemically bonded system, so we don't want any moisture being introduced, whether it's through saliva or through the air water syringe. Next, what we're going to be getting is the bond. So what the bond essentially acts like is a super glue. It's the adhesive layer between the tooth and the composite filling. This we don't want to put out ahead of time because if we do, then what happens is that bond, being a light cured material, will end up hardening in the DAPN dish just like this, and then it's not usable. We're going to recap our bond. Now this is a communal tub, so just make sure that this gets wiped at the end of the procedure. You're going to grab your DAPN dish, your micro brush, and if it bends, so if it has a little perforation, go ahead and bend that. And you're going to hand this to the doctor underneath the patient's chin, ready to go, pre-dipped, and they're going to grab it. I always like to keep my DAPN dish just below the patient's chin throughout this whole step so that when or if they need to re-dip the bond, then they can. They're going to apply this to the prepared surfaces. There are primer adhesives where they're a liquid etch and a liquid bond. There's a 2-in-1 system. There's also the, like we have, the acid etch and then the liquid bond. Now, if we apply the liquid bond, typically what they're going to want to do is do a quick little air dry just to ensure that there is no puddles, essentially, of the bond, so no thick layers of it. What I like to do is take my air water syringe tip off to the side and test that it's air first before I do this and end up spraying it with water. 3-second air dry there, so your little hair dryer. You're going to make sure that this curing light is set for 10 seconds, and we're going to cure the bond for or 10 seconds. Now I'm thinking ahead, the next step. The doctor is going to want to start applying the composite. But because this particular filling on an anterior tooth happens to be involving the interproximal, so the distal, they're going to want what's called a matrix system, something that's going to go between these two teeth, separating them so that when I place my filling, it doesn't stick to tooth number 7 and end up creating one large tooth. So for the anterior teeth, the matrix system of choice is typically your clear mylar strip. It's just a thin piece of clear plastic that essentially you floss in between the teeth and create a wall between tooth numbers 7 and 8. They can go through with a wooden wedge. This is going to go through the lingual embrasure, so it goes through the tongue side of the tooth and helps to wedge that into place. Doesn't work the greatest on these fake teeth, but definitely does on real teeth. The composite gun, you're already going to have preloaded with your composite, so to take it in and out, it pops in and out very easily in most cases. You would have already selected the correct shades, so you can find the shades on the caps themselves. So this is an A2. This is a one patient use product, so there would be a cap on here you take off prior to handing it to your doctor. Again, under the chin in the position used so they can grab and go. Thinking the next step ahead, they're going to want some kind of composite placement instrument. There are lots of different instruments that are out there available. The two that we have in our kit set up, we call it our gold composite instrument and our plastic composite instrument, which these we have a couple different colors and different sets, so they might be black or white or clear, but just know that the gold has the gold color and the plastic has the plastic look. There are multiple instruments with different purposes in their design, but it is just preference as to what your doctor prefers to use, which you'll then know and anticipate that. They're going to squeeze the composite gun to get the composite to start extruding out. And this is a really thick plastic, almost like a paste. And so it can be kind of tricky to get it to stick to the tooth, especially when we're working with these fake plastic teeth. You'll notice that it's a little harder to work on these than a live patient. You know, their tooth might be loose in the socket or this might pop out. So try not to get too frustrated when it comes to the fake teeth. As the doctor is using the placement instrument, a little trick of the trade, it's going to make you look a lot more polished, is you're always going to want to make sure that you have a piece of 2x2 gauze just below the patient's chin. So as they're working, they can stick their instrument out and you will wipe it clean as they go. When they're happy with the shape or they're ready to cure that layer of composite, we are then going to set it for 20 seconds and cure all the surfaces as needed. There are lots of techniques as to placing the composites. You know, it is an art, just like with any other type of art, there's lots of techniques to it. So there is a flowable composite that comes in different shades, like this is an A3. This is just a much thinner material than that paste that we were using, so it's great in really small cracks and crevices. You extrude it out just like you would your sealant material, so you squeeze and it comes out really runny. It also helps to fill in any kind of gaps. So if there's a small gap between the filling that you put in and the tooth itself, then they can go through and squeeze and syringe it in there to help create more of a seamless look to it. Obviously, this is not a very pretty filling we have right now. Different settings for different products. So this one's on like a pulsating setting on the curing light. Other ones are a constant light. Make sure that you know what your product requires. They're always going to want to check the bite, and especially if it's an interproximal, they're going to want to use floss to check in between. But the articulating paper goes into your Miller forceps by squeezing and opening, placing it in like a flag, and having them chomp chomp, slide side to side, to then evaluate should these be adjusted. If they need adjusted, then we can use different burrs like the finishing burr set. Each of these have different names and functions, but collectively, this is a finishing burr set. When they're done, the patient is ready to walk out the door, smile, use that tooth to eat because it is completely set up and there are no restrictions in regards to that. Now there are restrictions because they're numb. They're definitely not going to want to eat anything that's hot temperature wise, or maybe they wouldn't know how hot it was. Usually just if the numbing wears off, that's the best time to then go ahead and eat and drink. But it's not going to make it fall out. It's not going to make it, more sensitive, but there can be some sensitivity. Anytime that we work on your teeth, there is that slight chance there can be some sensitivity. So make sure to educate your patient that we just worked on your tooth. It's normal for a couple of days that it might be a little sensitive. Now, if it persists or it's unbearable, give us a call, and it's a possibility that maybe that bite's off because sometimes the bite registration paper doesn't pick up what needs to be fixed. And this should help you to get a better understanding of the general step-by-steps of a composite procedure.